Hello, and welcome to our first monthly webinar in 2021. Our topic today is Medicare Telehealth, an updated overview. I am Cassidy Avila with the Center for Optimizing Rural Health at Texas A&M University, and we are so glad that you are able to join us today. It is my pleasure to moderate this webinar and introduce our esteemed speaker, but before we do that, I want to let you know that all participants are muted, but we do encourage you to type your questions into the chat box during the presentation. At the end of the presentation, I will present your question. If you would like, you may select my name from the drop-down box in chat, Cassidy Avila, and I can ask a question on your behalf anonymously if you don't want to type it into the chat for everyone. We are recording this webinar and we'll share it on our website and our YouTube channel with all of our past webinars. And I do want to let you know that today's presentation will not include slides, but will be audio only. But the speaker will gladly share some resources and a couple of slides after the presentation for your reference. So it is now my pleasure to introduce to you Ms. Emily Yoder. Emily is an analyst with the Division of Practitioner Services, DPS, in the CMS Center for Medicare. She has worked on Medicare physician fee schedule rate setting and policy development since 2015, including primary care, evaluation and management visits, communication technology-based services, and Medicare telehealth. She holds graduate degrees from the University of Chicago and as a Fulbright Fellow from the University of Warwick in the United Kingdom. So Emily, thank you for being with us today. I welcome you, and you have the floor.
Thank you so much, Cassidy. Can you hear me all right?
Yeah, you sound great.
Awesome. Yes, thank you, Cassidy, and thank you so much for having me. I'm happy to provide this overview for you today. So I'm going to basically be covering payment policy for Medicare telehealth and also payment policy for other services that utilize communication technology, both prior and during the public health emergency for COVID-19. I'll then be providing an update on the calendar year 2021 Medicare physician fee schedule and the policies in that regulation for that pertain to telehealth. I apologize for not having slides prepared. The information that I'm covering today, I don't have a slide deck that covers all of it. However, I'm happy to share the slides that I have, and also I can provide links to other materials that will essentially cover the information that I am presenting to you today. So with that, just a little bit of an overview as to how telehealth services are reimbursed. They're reimbursed off the physician fee schedule, which is a $90 billion payment system. The payments under the PFS are resource-based, and they take into account physician or other practitioner work, practice expense, which are things like clinical staff, time, equipment, and disposable supplies, and malpractice insurance. Payment is made at the level of a HCPCS code, with each code generally describing a discrete service. So for purposes of physician payment policy, we tend to divide the world of virtual services into those that we consider to be Medicare telehealth and those that are not Medicare telehealth. So to start with Medicare telehealth, these are services that would otherwise occur in person and are paid at the in-person payment rate. This is a very important point because, as I said, the PFS is a resource-based payment system. And generally, outside of Medicare telehealth, services that are furnished using communication technology, which I will cover in more detail a little later, must be valued to account for the efficiencies that come from furnishing a service remotely. But Medicare telehealth services are not described or valued as remote services. And so basically they are considered to be the same for payment purposes as an in-person service. They are subject to restrictions on geography, site of service, and practitioner type. And the Medicare telehealth benefit was really meant to improve access to care for beneficiaries in rural areas. So that's Medicare telehealth. Non-telehealth services, or what we sometimes call communication technology-based services, these are not substitutes for in-person services. And so they're actually valued accordingly, with generally a lower payment rate. These are things like the virtual check-in, interprofessional consultations, remote patient monitoring, et cetera. So first, I'm going to dive a little bit further into Medicare telehealth. So Section 1834M of the Social Security Act lays out the specific circumstances where Medicare will make payment for services that would otherwise occur in person, but instead are furnished using communication technology. So the beneficiary must be in a rural area. They have to be in a medical facility. So that means they cannot be in their home. Now, there are a few exceptions. Congress has amended 1834M to remove the geographic and site of service restrictions for beneficiaries with end-stage renal disease, for diagnosis and treatment of an acute stroke, for beneficiaries with a substance use disorder and co-occurring mental health disorder, and very recently for services pertaining to mental health. The statute also limits the range of practitioners who can bill for telehealth. There's actually a list of these practitioners in the statute itself. So most significantly here is the statute excludes therapists. So these are physical therapists, occupational therapists, and speech language pathologists. They cannot bill for telehealth. The statute specifies that telehealth must be furnished using telecommunications technology. We have a long-standing regulatory interpretation of the term telecommunications technology to be live two-way audio-video communication technology. Now, there is an exception here for asynchronous or store and forward communication technology, but that is limited specifically to federal telemedicine demonstration projects in Alaska and Hawaii. So with a few exceptions, Medicare telehealth services are described using existing HCPCS or CPT codes. And as I said, these are not valued to pay as if they were remote services. A list of these codes is maintained on the CMS website, and every year we consider public requests and at times have actually conducted our own internal review to identify services that should be on the telehealth list. So this process is conducted through the physician fee schedule notice and comment rulemaking process, and I'll discuss that in more detail. In certain circumstances, CMS has created Medicare-specific coding to describe a portion of a service when we do not believe that the full service could be furnished using two-way audio-video communication technology. So for example, in the instance of critical care, we've received public requests to add those CPT codes to the Medicare telehealth list. What we did is that in prior years rulemaking, we actually articulated that we did not believe that the full scope of service elements described by those CPT codes could be furnished remotely, and that instead, just due to the potential acuity of the patient, would require an in-person interaction. However, we did believe that there were portions of the service that could be furnished remotely. And so we actually created Medicare-specific coding to describe a consultation service that is provided when a patient is in the critical care setting. So that is Medicare telehealth. I'm now going to discuss how CMS or how Medicare pays for other services that are furnished using communication technology. So we've actually had a long-standing policy of paying separately for these sorts of services and not considering them subject to all of the telehealth restrictions in 1834M. So for example, we pay for remote interpretation of diagnostic tests, also for care management services, and even the global surgical packages could include the use of some kind of communication technology as part of sort of the furnishing of that service. That being said, there has been little by way of discrete coding to describe services provided using communication technology. However, over the last several years, even before the public health emergency, we've been working on changing that. So because Medicare telehealth really encompasses services that would ordinarily be furnished in person, what we call communication technology-based services are defined as not being in person at all, or sort of inherently non-face-to-face, or in fact, as preventing an in-person service. An example of this would be the virtual check-in. So this is a short service that is furnished using synchronous communication technology to assess whether an in-person visit is needed. So if an in-person visit results, then the virtual check-in is considered bundled into whatever code is billed for that in-person service. However, if there is not an in-person service, so say, for example, you call your doctor and you're feeling poorly, and the doctor listens to you describe your symptoms, and rather than saying, hey, I need to see you in person, please come in for an office visit, they say, no, you know what, we think this is just a common cold, like drink lots of fluids and get some rest. Previously, that service would just not have been paid. There would be no mechanism for the physician to receive payment for the resources associated with evaluating whether or not you needed to come in person. But now they can bill for a virtual check-in, and that provides some payment for the work associated with preventing an in-person visit. So we also now pay for interprofessional consultations. These are practitioner to practitioner consultation services, and also e-visits. E-visits are similar to the virtual check-in, except for the interaction is over like an online patient portal. We also pay now for certain remote monitoring or remote physiologic monitoring services. So now I'm actually going to turn to the public health emergency and the sort of waivers and flexibilities that CMS used to really expand the opportunities for Medicare telehealth and for to relax restrictions around those communication technology-based services that I just described. So in response to the pandemic, CMS really moved quickly to expand access to telehealth and other kinds of virtual services. To give you an idea of how quickly we moved, we basically did what amounts to 20 years of policy making around Medicare telehealth within the span of what was like 2 months. So it was very, very rapid. So we used a combination of statutory waiver authority that was provided to us by Congress as part of a number of the relief acts, most significantly the CARES Act, and then our own regulatory authority. So using waiver authority, we were able to remove the restrictions in 1834M surrounding where the beneficiary must be located, both the geographic area and also the site of service. So now beneficiaries in rural and urban areas can receive telehealth services, and also the beneficiary can remain in their home for the full range of services that are available right now as Medicare telehealth. We waived the list of practitioners that is enumerated in the statute, and we waived the requirement that the technology be two-way audio video for a subset of counseling and educational services. We also began paying for audio-only evaluation and management services, and I will cover those in more detail. We also waived the requirement So the waiver authority used to remove these restrictions is tied to the duration of the public health emergency. So these flexibilities will terminate with the PHE. And these are all statutory restrictions. So to make any of these flexibilities permanent, we would require an act of Congress. So as a companion to these waivers, we undertook emergency rulemaking to remove any remaining regulatory hurdles. There have been, I believe, now 4 interim final rules, but it really was the first 2 that were published in late March and in early May, respectively, that addressed telehealth and other types of remote services. So we first expanded the range of services that can be furnished as telehealth by adding over 135 new services to the Medicare telehealth list. And these included a full range of services from ED visits to certain therapy services. For Medicare patients with end-stage renal disease, we waived the requirement that, through rulemaking, we made it so that clinicians no longer have to have one hands-on visit per month for the required clinical examination of the vascular access site. Prior to this flexibility, the way that the law is written, and this is actually something that is in the statute, but not for telehealth, but for ESRD, if a beneficiary is receiving ESRD services in their home, they have to have one in-person visit per month for the first 3 months, and then one in-person visit every 3 months thereafter. This is just to make sure that there is adequate hands-on, as I said, examination of the vascular access site. So we waived that requirement for the public health emergency through using our rulemaking, but also enforcement discretion. We're just not enforcing that part of the law right now. So I mentioned audio only telephone evaluation and management or assessment and management visits. So this is a set of 6 codes, 3 for practitioners who can separately report evaluation and management visits, and 3 for practitioners who cannot. And we had actually long considered these services non-covered under the physician fee schedule. So in the first interim final rule, for purposes of the public health emergency, we changed these codes from non-covered to covered and began making separate payment. We also elected not to enforce the requirement that's actually in the code descriptor that these services only be provided to established patients. After that rule, we began hearing from the stakeholder community that these codes were being used as stand-in for for sort of office visits in instances when beneficiaries did not have access to or did not want to use the two-way audio video telecommunications technology that would be required to bill for those office visits as Medicare telehealth. And as such, the payment rates for these audio only visits were not really accounting for all the actual resource costs associated with furnishing these services. So therefore, in the second IFC, we increased the payment rates for CPT codes 99441 through 99443. These are the codes for practitioners who can independently bill for E&Ms. And we increased the payment rates to match the payment rates for the level 2 through 4 established patient office visit codes. In order to do this, just because of the way that the law is, we had to do a bit of a workaround. We added them to the telehealth list and then waived the audio only requirement for telehealth services. For our communication technology-based services, we removed the requirements that these be furnished only to established patients and expanded the practitioners eligible to bill for these services from practitioners, again, who could independently bill for E&Ms to practitioners who cannot, so that, for example, licensed clinical social workers, clinical psychologists, and therapists could bill for these services when applicable. With regard to remote physiologic monitoring, during the PHE, we are allowing consent for RPM services to be obtained once annually, including at the time that the service is furnished. We're also allowing remote physiologic monitoring services to be provided to new patients. And we're allowing the codes to be used for monitoring of patients with acute and or chronic conditions, including, for example, an acute respiratory virus. I would say some of these are actually, I will cover again, because a few of these we've made permanent as sort of non-PHE policy. But this is an example of the types of things, the flexibilities that we put in place during the public health emergency for RPM. Finally, we also established a policy on an interim basis for the duration of COVID to allow remote physiologic monitoring services to be reported to Medicare for periods of time that are fewer than 16 days of 30 days, but no less than 2 days, as long as the other requirements for billing the code are met. And finally, before I turn to the CY 2021 physician fee schedule rule, I did want to talk a bit about payment for hospital services during the PHE, but with the caveat that I work on physician payment policy, not hospital payment policy. So my expertise here is very limited, but I did want to touch on the hospitals without walls flexibility. So hospitals under the Hospitals Without Walls have the option to reclassify a beneficiary's home as a provider-based department, and then the hospital can bill for certain services provided by staff of the hospital to the beneficiary, even though as if these services were provided face-to-face. So basically, the clinical staff can be in the hospital, the beneficiary can be in their home, and because those two things are considered to be part of the same hospital, the hospital can bill for services provided by clinical staff as though they had happened just in the hospital face to face. As both the beneficiary and the clinical staff are technically in the hospital, even if they're not in the same physical location, these are not considered telehealth services, even if telecommunications technology is used to facilitate provision of the service. Excuse me. So obviously, the implementation of all of these flexibilities during the public health emergency has influenced how we think about telehealth and similar services. So the portion of the CY physician fee schedule that I'm about to cover should really be taken as what we hope is the start of a larger conversation with our stakeholder community about the role that many of these flexibilities put in place during the PHE could potentially have after the PHE has ended. I think most significantly here is the question of what services in that broad range of services that we made available as telehealth during the PHE should be telehealth services after the PHE ends. Again, I will underscore that many of the flexibilities pertaining to telehealth, particularly the geographic and site of service restrictions, we waived those using waiver authority. And so, as I said, those we don't have, CMS does not have the regulatory authority to change those. That requires Congress. So before I get into those finalized policies, specifically regarding adding services to the telehealth list, either temporarily or permanently, I would like to talk a little bit about the criteria that CMS uses to determine whether or not a service should be available as telehealth or not. So the statute only requires that CMS create a process for adding or deleting services from the Medicare telehealth list. We've used our regulatory authority to create what we call categories of criteria that we use to evaluate potential telehealth services. So the statute describes services similar to professional consultations, office visits, and office psychiatry services. These are the three types of services that are actually in the statute itself. So we define what we call our category 1 criteria for evaluating whether or not a service should be on the telehealth list as services that are like these three categories of services. However, we recognize that there may be additional services that could be provided as telehealth that don't fit into the classification of consultations, office visits, and office psychiatry services. And so this is where our category 2 criteria come in. So category 2 criteria, these are services that are not like those services described in the statute, but that we will consider adding to the telehealth list based on evidence of clinical benefit. So those were the two sets of criteria that we would use to evaluate telehealth services prior to the public health emergency. So in response to the PHE and to the wider range of services that are available right now, we recognize that clinicians are still experiencing sort of developing experience with this wider range of services, and that at the conclusion of the public health emergency, we really didn't want there to be just a dramatic cutoff for all of these telehealth services. So we actually created a third temporary category of criteria for adding services to the list of Medicare telehealth services. This is category 3, and it describes services added to the Medicare telehealth list during the public health emergency that we think are likely to be able to meet either the category 1 or category 2 criteria if evaluated through our standard rulemaking process. So these services will remain on the telehealth list up through the calendar year in which the PHE ends. And this will also give the community time to consider whether these services should be available permanently as telehealth outside of the PHE. So the real idea behind category 3 was an acknowledgement that right now clinicians are focused on treating patients. They are not focused on putting together requests and documentation to add services to the Medicare telehealth list. and that their experiences with a broader range of services might be able to inform requests submitted as part of our standard PFS rulemaking process. With that in mind, we certainly look forward to evaluating these requests as part of annual rulemaking. So when it comes to what we finalized with the physician fee schedule for CY 2021, we are finalizing the permanent addition of a number of services to the Medicare telehealth list on that category 1 basis. And I think the most important thing here to understand is that there are a set of services that are being added permanently to the Medicare telehealth list. These services will be on the telehealth list regardless of the public health emergency. They are there permanently. We would have to undertake rulemaking to remove them from the list. But there's also, and these services that we're adding this year include lower level established patient home and or domiciliary visits, assessment and care planning for patients with cognitive impairment, group psychotherapy, and 2 add-on codes that are associated with some of our previously finalized office outpatient E&M policy. So then those are the permanent services. And now we have the category 3 services or the temporary services. So services that we are adding to the telehealth list on a category 3 basis include all levels of emergency department visits, certain therapy services, higher level established patient home and or domiciliary visits, certain psychological testing services, nursing facility discharge day management, and a range of critical care services. Again, these services will be on the Medicare telehealth list up through the year in which the public health emergency ends. Now, I'm going to turn to a number of other telehealth policies that are in the CY 2021 physician fee schedule. So, in response to stakeholders who have stated that the once every 30-day frequency limitation for subsequent nursing facility visits furnished as telehealth provides unnecessary burden and limits access to care, we implemented these frequency limitations. It's once every 30 days for subsequent nursing facility visits. There's a 1 telehealth visit per 3-day limitation for subsequent inpatient care, and then a 1 a day limitation for critical care consults. All of these, we put these in place because we were concerned that beneficiaries whose status was so acute that they were in some sort of an institutional setting, that we really wanted to make sure that they were receiving necessary in-person care, and that by allowing these types of services to be provided as telehealth, that we weren't creating an incentive to just do all of the care virtually. So stakeholders in particular have said that this 1 visit as telehealth every 30-day for nursing facilities was quite burdensome and really limited access to care for beneficiaries in this setting. So we actually proposed to revise the frequency limitation from 1 visit every 30 days to 1 visit every 3 days to align it with the 1 telehealth visit every 3 days for subsequent inpatient care. However, based on information from commenters about creating a disincentive for in-person care, and after additional consideration of how patients in the nursing facility setting in general tend to have longer lengths of stay when compared to patients in the inpatient setting, we actually finalized a frequency limitation of 1 subsequent nursing facility telehealth visit, 1 every 14 days. With regard to our communication technology-based services, we clarified that licensed clinical social workers, clinical psychologists, physical therapists, occupational therapists, and speech language pathologists can all bill for communication technology-based services. For some codes, such as the e-visits, there were actually 2 sets of codes. 1 for practitioners who can independently bill E&Ms and 1 for practitioners who cannot. And this was really just a clarification that those codes that were for non-E&M billing practitioners, these are examples of the types of practitioners that could bill for these. But for the virtual check-in and another CTBS service, a remote evaluation of a pre-recorded image or video, we actually had to create separate codes for these non-E&M billing practitioners. So we created 2 new HCPCS G codes for them to bill. So as I mentioned, we are paying for audio only E&M services during the public health emergency. However, we did not propose to continue to recognize these codes under the PFS in the absence of the COVID-19 public health emergency. However, we noted that the need for audio only interactions could remain as beneficiaries are continued to, even in the absence of a COVID-19 public health emergency, beneficiaries may still want to try to avoid things like places like doctor's offices, just out of concern for other types of infections, or, I mean, even in the absence of the PHE, COVID will still exist. So the beneficiaries just may not be as comfortable going into the doctor's office as they would have been prior to the public health emergency. So we sought comment on whether CMS should develop coding and payment for a service similar to the virtual check-in. The idea here being that just because beneficiaries are going to be potentially much more cautious about going into the office, that more time might be needed to assess the necessity of an office visit rather than the sort of like 5 to 10 minutes that is described by the virtual check-in. So based on the support from commenters, we established payment on an interim final basis. So as temporarily, but still active January 1st, 2021. And we will have to undertake rulemaking to decide what we want to do with this code, but it is active for the time being, and it describes 11 to 20 minutes of medical discussion to determine the necessity of an in-person visit. So finally, I'm going to talk a little bit about supervision. So during the public health emergency, we adopted a policy that revised the definition of direct supervision to include virtual presence of the supervising physician or practitioner using interactive audio, video, real-time communications technology. Prior to this revision of policy, direct supervision, the supervising practitioner had to be in the same location as the practitioner that they're supervising and had to be immediately available. And so we were able to revise, for purposes of the public health emergency, that definition to include being available through virtual means. Again, and that is audio, video, real-time communications technology. So we are finalizing continuation of this policy up through the year in which the public health emergency ends, or December 31st, 2021, whichever is the later date. And this will give us time to continue to evaluate whether this policy should actually be adopted on a permanent basis, or whether this is a policy that really was important during the public health emergency, but that perhaps poses too many risks in terms of program integrity or beneficiary safety and quality of care to be a permanent policy. I would note that for a number of these issues, specifically the direct supervision via virtual means and a number of the services that we added to the telehealth list temporarily, or in fact services that we did not add either permanently or temporarily, but that are still available during the public health emergency, the agency is actually undertaking its own study to sort of develop a better understanding of how these flexibilities have been used. So while we are very much relying upon the public to provide us with information about their experiences with these flexibilities, CMS is also undertaking its own review as well. And these are things that we will definitely be taking into consideration through future rulemaking. So finally, for remote patient monitoring, these are the policies that we are actually finalizing permanently for RPM. So we clarified that after the COVID-19 PHE ends, that there must be an established patient-physician relationship for RPM services to be furnished. I don't know if I covered it earlier, but we exercised enforcement discretion on to allow RPM to be provided to new patients, but this is only during the PHE. And after that, it ends, then it will go back to just being for established patients. So we did finalize that consent to receive RPM services may be obtained at the time that the RPM services are furnished. We finalized that auxiliary personnel may provide services described by CPT codes 99453 and 99454 incident to the billing practitioner services and under their supervision. We also clarified that auxiliary personnel, that can actually also include contracted employees. We clarified that the medical device supplied to a patient as part of the RPM service must be a medical device as defined by Section 201H of the Federal Food, Drug, and Cosmetic Act, that the device must be reliable and valid, and that the data must be electronically, and that means automatically, collected and transmitted rather than self-reported by the beneficiary. We also clarified that at the expiration of the public health emergency, a full 16 days of data each 30 days must be collected and transmitted to meet the requirements to bill CPT codes 99453 and 99454. We clarified that only physicians and non-physician practitioners who are eligible to independently bill for E&Ms may bill for RPM services. We also clarified that RPM services can be medically necessary for patients with acute conditions as well as patients with chronic conditions. There was some confusion due to some language in, I believe, the code descriptors that suggested that maybe these codes were only for chronic conditions, but we are clarifying that no, in fact, these can be billed for treatment of acute conditions as well. For CPT codes 99457 and 99458, an interactive communication is defined as a conversation that occurs in real time and includes synchronous two-way interactions that can be enhanced with video or other kinds of data as described by the virtual check-in. For the virtual check-in, the only restrictions in terms of technology is that the technology must be synchronous. And so it can include an audio only, for example, phone call can definitely fall into the technology that's permissible for G2012. And we're just clarifying that the same policy is involved here as well. And then we further clarified that the 20 minutes of time required to bill for the services of these codes can include time for furnishing care management services, as well as the required interactive communication. So with that, I realize that's a lot of information. And as I said, I am happy to send along some slides and some additional information just to sort of provide resources like based off of all of the information that I've provided today. So with that, I will turn it back to you, Cassidy.
Thank you so much. We do have a couple of questions in the queue. So let me grab those for you, Emily, and we'll get them answered for you. Okay, so the first question is there a good place to go for a concise summary of all of these waived and modified services that are reimbursable?
Yes, I will provide that link as part of the resources that I pass along. But there's a web page on the CMS website that is just a summary of all of the waivers, and not just for like Medicare telehealth or physician services, but for hospitals, for home health. It just is a good central location where all of those resources are located. So I'll definitely share that link.
Perfect, thank you. The next question, can this telehealth service be implemented specifically for telepsychiatry in the ER?
So that is a really good question. Right now, we are limited to the services that basically limited to the CPT codes that describe services furnished in the ER setting. So those are the emergency department visit codes, and they're not condition specific, but they do have certain requirements around medical decision making and things like that. So I'm not aware of, likewise, certain psychotherapy services. Those could also be provided to a patient that is in the ER setting. I'm not aware of any coding currently that exists specifically for telepsychiatry. However, as I said, there's numerous codes that can be billed in those instances. I just don't know of anything specific.
Thank you. Next question. Can you elaborate on Medicare payments for telehealth encounters in the pre-hospital, such as 911, fire, EMS setting, specifically for public safety agencies that will or will not be part of the ET3 model?
That is a really good question as well. And can that be sent to me in writing? I don't work on ET3, but I can definitely pass it along to the folks that do.
Absolutely. Yeah, I will follow up on that, and we will get back to you on that question. Next question. Can the RPM 16-day data be manually entered into the EMR if the data is dumped into a depository outside of the EMR?
So that is another question that I would like, if you could send that to me. I actually, my payment policy I work on things sort of similar to RPM. I'm actually not the RPM subject matter expert. So I would like, if that can be sent along to me, I can make sure that she gets that question.
Absolutely.
Thank you.
Thank you. Next question. As of now, what date is considered the end of PHE?
So unfortunately, I should know this, but I don't. I know that it's been extended again, but I'm not quite sure of the end date.
Okay. Is there a way that we could find that out or a place to go?
I think I can find it. That's easy for me to do. So I can send that too.
Perfect. Thank you so much. Will the slides be sent to our email, or is there a location we should access the link? Yes, we can make sure the slides go out to your email address, the slides with the resources that Emily has mentioned. And then for an emergent teleconsultation, are there times, the questions are moving on me. We have more coming in. Apologies. For an emergent teleconsultation, are there time restrictions or modality diagnosis restrictions?
So if this is a question about the emergency department visit codes, then no, there's no restrictions on diagnosis or anything like that. The requirement is that essentially you meet the definition of the service as it is in the CPT code descriptor.
Okay, and then we had a comment last I heard the PHE ends 1/21/21, but as Emily said, she'll follow up and we'll get the answers for you guys. Let's see, next question. Sorry, I must have missed the response. Can this telehealth service be implemented specifically for telepsychiatry in the ER? I think someone just didn't hear your response to that question.
Yeah, no, that's fine. Sort of to be brief, I'm not aware of any specific codes that speak to telepsychiatry. However, I do believe that there are existing coding that is available as telehealth. For example, the emergency department visits or certain psychotherapy for crisis is another telehealth service that is available. So I think that there are codes that can describe something like telepsychiatry, but we don't have any specific coding for that particular modality of care.
Great, thank you. And then we had a comment that the PHE does not end on 1/21/21, and then she linked out to something. So if anyone wants to click that link, that's available for everyone in the chat.
Yeah, and that probably would have been the link that I would have provided. So thank you so much for that.
Yes, thank you, Katie. Let's see, what else do we have? Did you touch on AWV? Sorry if I missed it. As far as doing by telehealth. So I'm sorry. Let me state it again. Did you touch on AWV?
Yes, so the annual wellness visit has been on the Medicare telehealth list for quite some time, even prior to the public health emergency. However, during the PHE, the AWV was one of those services where we waived the requirement that it be two-way audio video telecommunications technology. So during the PHE, the AWV can actually be furnished using audio only communication technology. So I'm aware of the fact that the AWV requires reporting of certain types of biometric data, and we've been unable to, through either rulemaking or waiver up to this point, do anything about the requirements that the beneficiary has to report that data, because we're aware that beneficiaries may not necessarily have in their homes access to the kinds of equipment that would be used to collect that information. However, while that still must be reported as part of the service, we are allowing self-reported information. So if the beneficiary can access the kinds of equipment that they would need to take their blood pressure or their height and weight, et cetera, then self-reported data can definitely meet those requirements. But this is only for that particular flexibility, again, is only for the public health emergency.
Great, thanks. Let's see, next question. Are there separate telemedicine codes that change when medical imaging is provided? Does each state need to apply these rulings in order for practitioners to bill, and can it cross state lines?
So I don't believe that there's separate codes that involve medical imaging, particularly, like specifically for telehealth. I know that to meet the requirements to bill certain evaluation and management services, things like the reviewing of diagnostic tests or imaging can count towards whatever the threshold is to bill those services. So there's nothing specific to telehealth there, though. And in terms of the states, that is a question that you'll need to send to me in writing, because that is not really my area. I know that there have been some flexibilities for the PHE in terms of how states sort of licensing and things like that, but I don't know them off the top of my head, and I would need to sort of research that a little bit more or direct it to someone else in the agency.
Okay, we can send that one to you as well. And thank you to everyone that's doing the research on the PHE extension. So we had a couple of comments, and it looks like it was extended 90 days out from 1/21, so somewhere around April 21st, 2021. Okay, and I think that's all we have in the queue right now. You do have a few minutes left if you want to get, oh, let's see, I think we did get another question. Okay. I apologize if you touched on this already. Has there been a discussion about opening up the telehealth appointments across state lines for established patients? For example, an established patient is wintering in another state but wants to continue care with their PCP via telehealth while wintering.
So I know that, and again, I apologize. I believe that there's a flexibility here for the public health emergency, but I believe that outside of the PHE, the physician or other practitioner has to be licensed in the state where the beneficiary is located. I'm not aware of anything that sort of, any further information on that, but that is a question that I would welcome in writing as well.
Okay. Okay. Okay, so as I was saying, we still have a few more minutes if anyone else wants to get a question in. I'm going to go ahead and post a survey link in the chat box since we don't have questions right now. This is just a 60-second survey that lets you respond to the webinar and what you might like to see as a follow-up or in future webinars. So if you have 60 seconds, we would appreciate you clicking that link. I don't see anything else coming in, but I will talk for just a second to give someone a chance to keep typing. So as we have stated, we will follow up this webinar with an email to you, and we will provide the resources that Emily has mentioned, and then we'll get your questions over to her. And when those responses are available, we will send those out to you. But we've had some great questions and some great conversations, so we appreciate your participation. Emily, I don't see anything else coming through, so that might be it. But if you think of a question or If you're typing right now and we don't see it, then we welcome you to send an email to us, and we'll make sure that we get your question passed along. But I thank you for your time. And Emily, thank you so much. This has been a really excellent and informative webinar, and we're so glad to have had you on today.
Thank you so much for having me. And I welcome additional follow-up questions. I realize it was tons of information, and there's also going to be additional resources provided. So please don't hesitate to reach out. And thank you so much for having me.
Great. Thank you. Thanks, everyone. Have a wonderful afternoon.